Welcome everybody to our Wednesday morning session. How are we all feeling? Woo, indeed. What a place. Hopefully everyone's had a chance to get out, explore what's around. Some great photos coming through. I promise we will do them today, so please keep submitting them. As we get towards the end of the week, that's usually when all the photos start coming through. So if you want the greatest chance of winning a prize, now's the time to be submitting your photos. You may have seen some changes. We've moved the flowers. We've made the screen a little bit more condensed. Hopefully that will help a little bit, but please, if you do have any other feedback to let us know that what might help with viewing, that'd be great. And also at the end of the week, you will get a survey form to provide feedback. Please, if there is anything during the week though that we can do to help out, that we can change to make your life easier, please let us know, and that would be much appreciated, because this really is about putting events on that everyone wants to come to and enjoy. So we really do value every bit of feedback that we can get. 4 presentations today. We're going to do 2 presentations, have a break, then another 2. If you do need to stretch your legs, move around, please feel free to. There is space at the back. For those that did yoga this morning, it was challenging. There was a lot of twisting and turning. So yeah, if you need to lie down or stretch out again, I completely understand. But let's get cracking on with it. First presentation, pretty excited. Tasha's been to a number of our conferences. She very kindly offered to present for us. We absolutely jumped at the chance, so please make her feel nice and welcome. Tash, coming up.
Everyone. Oh, hopefully this works. My name's Tash. I work at Fiona Stanley Emergency Department in Western Australia, and that is a mixed ED with adults and paediatric patients. And I've done ED for about 15 years, but I've worked with children for about 17, and I've been a clinical educator for the last 4 years. So hopefully I can help you guys get a structured approach to dealing with some sick neonates. I'm hoping that this presentation will help you feel a little bit more comfortable on what to do after you get someone who's very, very sick and very, very small in. But I also recognise that you might have had some traumatic experiences dealing with some small humans. So if anything does come up for you, if there's an emotional stressor, anything like that, please feel free to pop out of the room. And if you want to have a debrief or a chat later on, I will be here till the end of the week. Thanks, Sheree. I'm my biggest fan. All right, can I just get a show of hands? How many of you guys are pre-hospital? So paramedics, ambulance, okay, fab. How many of you are nurses? Loads, okay, and doctors? Okay, fabulous. Well, I'm hoping that you will be near enough to someone, because we're going to collaborate a little bit today and learn from each other and think about some of the resources that are available to each other and help each other out. So we're going to have a little bit of a focus on sepsis today, but the reason that there are potatoes is that neonates are my absolute favourite population of paediatrics. We have come a long way evolutionarily wise, and in the interest of bipedalism and having big mammal brains, we do most of our growth outside of the womb. So neonates are very reliant on their caregivers, and they are potatoes. The reason I want to focus a little bit more on sepsis is that it can have really catastrophic effects, especially for preterm neonates. It's about up to a 30% mortality rate in Western Australia. And we will be talking about some of the anatomical and physiological challenges for treating neonates. We won't go through absolutely everything because it's only a short presentation, but we will try and collaborate a bit. We're going to use the stable structured approach to post-resuscitative care. And we're going to try and learn about each other's practical approaches to applying some of these strategies in the clinical setting. This is not a neonatal resus presentation. I would highly recommend you guys do a neonatal resus course at some point. I know there's some available in Australia, and there's some e-learnings available if you'd like to have a look after this course. Okay, so we're getting a call. And our case study is that you're asked to respond to an ex-premature neonate who had resuscitative protocols for apneas lasting approximately 20 seconds. We know that they are a 5-day-old neonate. They were born at 36 weeks. There was some maternal cannabis use, and the baby is small for gestational age. We're getting an A to E, and the baby has a patent but weak cry with their airway. Their breathing is supported intermittently with bag valve mask ventilation. They have intermittent apneas, and their SATs are 88%. They're mottled, their fontanelle is slightly depressed. They're cool peripherally, and their capillary refill time centrally is 4 seconds. They're also floppy. Does anyone feel comfortable with this? Show of hands, who's nervous? Are there any immediate concerns or red flags at the moment? Everything? Yeah. Where do you guys begin? So this is hopefully going to give you the structured approach, which will hopefully help to reduce your errors and your cognitive load when you're dealing with this kind of baby. Oh, hello. Just some assistance over there, thank you. All right, so we are going to consider a few things. So one of them is sugar, temperature, airway and breathing, blood pressure and heart rate, lab work, and emotional support. So a lot of you guys who are in crit care will be used to using the A to E approach. With neonates, oftentimes those of us that have been around the traps for a little bit longer will remember to keep them warm, pink, and sweet. A little bit racist, because not all babies are white, and it's a bit vague. So stable gives us a little bit more information, and it allows us to maintain homeostasis on a few different fronts. Small, tiny foot. Okay, sweet potatoes here, because we're talking about sugar. Our normal range of neonatal BSL is 2.8 to 5.8, and our literature tells us to try and aim to keep it around 3.3 if you can. So our brains exclusively require glucose to function. An adult brain requires about 20% of the circulating glucose that's in your bloodstream, whereas a neonate or a developing child requires about 40% in developmental stages. We don't store much glycogen when we are neonates, so we don't have many stores to pull from. And neonates and small children have really high metabolic rates. It actually increases when they're sick, especially things like sepsis, and even more so when they're premature. So basically, we are going to be trying to deal with a BSL of 2.6. So I want you to, in the next moment, turn to the person next to you, have a chat, and think about what strategies you might use to correct this. We won't spend too long on it. If you hear the sound of a baby crying, that means please pay attention to the front, and we will all we will all discuss, okay, if you're comfortable to do so. So please have a chat. Five more seconds. All right, thank you, everybody. So does anyone feel comfortable sharing? What are your thoughts and strategies on correcting this sugar of 2.6? Umbilical line and access. Okay, so we want to get access. So what are our options with neonates? Umbilical, okay, so intraosseous. 5 days old is okay if you soak it, yep. I've seen up to 10 days. So if you soak an umbilical stump for long enough, you can potentially be able to get a venous catheter in the umbilical vein for up to about 10 days. You've got to soak it in saline. Oh, potentially. So who here uses glucose gel in their practice? Okay, did you know with a neonate, because they are potatoes, they don't absorb it very well when you do it buccally. So the trick is to wipe with some gauze on the inside of their cheek and then use a few drops of mother's milk or formula, and then you can get them to absorb the glucose gel once you've squirted it into their inside cheek. Yeah. Any other strategies? Yes, absolutely. Very, very important that they're still awake and alive enough to swallow. Absolutely. Other theories, maybe someone could mention intravenous, because you're so good at getting intravenous lines in at the hospital. Yep. We could do intraosseous, so just care with not losing a limb when you put an intraosseous gun in. We also have the option of nasogastric or feeds, but the thing to remember is when you've got a very sick neonate, we don't want to feed them straight away because of that risk of aspiration. But also, if they've got periods of hypotension, which is very likely in this case, we can get a reduced blood supply to their gut and they can get an ischemic gut, which eventually would kill them. So only start with orals when they are feeling a little bit more stabilised. So it depends on how sick the baby is, but I would be doing it in this sort of stage at least half hourly. If you're giving glucose, the IV dose, the 2 mils per kilo of the 10% dextrose, you're looking at about 60 to 90 minutes of effectiveness generally. Okay, we're going to move on to our next one. Okay, this is about temperature. So we want to keep our babies between 36.5 and 37.4 degrees in the axilla. If you're taking that in rectally or with the skin, that can vary by about 0.4 degrees. Neonates are very unlikely to get febrile when they're septic. They're more likely to lose their temperature. And they lose it because they are potatoes. Once again, they have very thin skin membranes, so they're losing heat, they're radiating it out into the atmosphere, they're evaporating all of their liquid as well from their skin, which is quite silly, and they're very prone to heat loss through cold surfaces as well. So they can't shiver and they can't apply layers to themselves to correct that, and they rely on the goodwill of everybody else. So they have a couple of protective factors, but it's not amazing. So the one thing that they can do is when they get a cold stimulus into the hypothalamus, they release noradrenaline and they bring their limbs up. They're just trying to reduce their surface area and trying to reduce the amount of radiating heat. The other way that they can do that is by the metabolism of brown fat. Now, brown fat starts accumulating around 25 weeks of gestation, but it doesn't accumulate in any meaningful quantities until about 36 weeks. If you've got an underweight baby, they're unlikely to have very much of that anyway. So the body starts metabolizing that brown fat and then it produces heat, but then you lose all of your reserve, okay? It also requires oxygen and glucose, and we've got a baby that's already got a low glucose. He's not going to be able to metabolize that brown fat to keep warm. So septic and shocked infants, they really don't have very much hope of being able to do things. It's a spiral. So how are we going to correct this when we've got a temperature of about 35 degrees? Okay, I'll give you another short while. If you can have a chat, listen out for the baby crying. I'll give you a 5-second warning. 5 more seconds. All right, guys, let's get back to it. So, is anyone comfortable to share? How are you going to correct this temperature? Bring this baby back online. Oh, an overhead warmer, you say, which is a brand name Panda. Does anyone have access to one of those? Fabulous, great. Pandas are wonderful. They've got nice barriers to stop the wind, and they've got the overhead heat lamps. So normally we would set the temperature to be roughly a degree higher than what you've already got on the baby until you can get it stabilised. And we can also keep it warm on the nice warm surface. So don't ever leave your Panda turned completely off. Always keep it on standby mode so that it can keep warming. When you put the new baby on there, it won't lose all its heat into bed. Any other strategies? Go. Absolutely. Skin to skin. There are so many benefits of doing skin to skin for the baby and for the mum. So other than heat, you get lovely oxytocin, they get bonded, they love each other, and mum's actually going to want to care for the screaming, pooping child. Yeah. What else? Warm fluids, it depends on how quickly you're going to be giving them, because oftentimes with little ones it takes 10 to 15 minutes to get the fluids in. But yeah, absolutely, good strategy. What's that, Jack? A space blanket. Okay, well, neonates have different space blankets to adults. So you'll notice this lovely polyethylene wrap. Basically, put that baby in like a burrito so that you can consume it later. So I'm here all week, guys. This is how we do. So you can see it's got this lovely wrap. We've got it over the head as well. They've got this big fontanelle that's right next to some vessels. It's going to be leaking heat out into the atmosphere like nobody's business. What you can't see is that there's usually a little Velcro strip where you can actually access umbilical catheters and things like that, and you can access the baby. But it's basically putting them in a nice little plastic glad wrap kind of suit, and it keeps them nice and toasty. We also use this if we get the premature babies that come straight out the womb, because a wet baby can lose about 1 degree per minute of being out and exposed to the world. So if they're very premature, we don't wipe them, we don't dry and stimulate them, we just chuck them straight into the takeaway container. Bring them. Any other strategies you've got out there? I hear you say an incubator and or warm gases. So if you have got the option of an incubator, anyone? Yes, a couple of people. So you might choose to put that incubator up 1 degree to 1.5 degrees higher than what the baby's got until we can stabilise it. So similar to adults, if you've got a term baby, you're going to aim for at least 0.5 degrees Celsius warming per hour. But for pretermers, we can go a little bit faster. And the research says you can go 1 degree an hour, but for very preterm babies, you can go a bit faster. No consensus, just toast them up. You also might have an exothermic mattress, so nice and warm from a chemical reaction underneath them, but just be very careful to put something on top of it because you don't want to cause burns. And the other thing that we might choose is the warm gases. So if you've got the incubator with the option, you can put warm gases through there, or you can use humidified high-flow nasal prongs at a warmer temperature, because that will help with their insensible losses as well. Okay, shall we move on to airway and breathing? So normally it's just taught as airway, but I thought just pop some breathing in there because that's essential too, hey? The normal range for term neonates is about 30 to 60 breaths per minute. They are obligate nasal breathers because they haven't yet developed any of the pathways to use their mouth as yet. They have more type 1 muscle fibres than type 2, so they exhaust very easily and they don't have any reserves. And they also are periodic breathers. So I think, do most people use the acronym RATES to assess breathing? Okay, so same, except we're actually monitoring the rest rate over a full minute and not the 5-second homeopathic rest rate 16 to 18, St. John's. I'm not looking at you, Quentin. Alrighty, so we look for a full minute, and we know that they monitor the CO2 and the oxygen levels in their bloodstream, and then that goes to the respiratory centre and their medulla, and then it says breathe or not breathe. So I'm going to do a lovely impression of a neonate, but basically they sound a little bit like they just keep breathing kind of strangely. So you might see some irregular breathing, totally normal. You'll auscultate all 4 fields for 4 quadrants of the lungs. We're going to check for tracheal deviation. Neonates can get a pneumothorax very easily and quickly, especially if we're giving a microphone. Oh. If we're giving extra PEEP. And we are going to check their effort. So things you might see would be nasal flaring, head bobbing. You might see some rib recessions, and you might see some supra and subcostal rib recessions. You might see cyanosis, or you might see some unequal chest rise and fall. So when we're looking at effort, oftentimes I find that nasal flare, head bobbing, sounds like grunting, are really underwhelming sounds. So we'll play a video in a moment and see what you can assess. But I do just want to quickly mention, if your neonate is gasping, that is a pre-terminal sign, and you need help very, very quickly because they will arrest. Okay, so our little fella here, let's name him Spudley because I didn't think of a name until just now. His rest rate 66, he's got some nasal flare and head bobbing. So I just want you to watch this lovely video, courtesy of APLS, and let me know what you can hear and see, although the voiceover does give you the answers.
Small airway closure leads to hypoxemia, and the major increase in the work of breathing, together with sleep disruption, leads to fatigue and respiratory failure. In some infants, particularly those born prematurely, there can be apneic episodes. Additional inspired oxygen is usually necessary, and respiratory support may also be required.
Okay, so what did you guys see? Bad? Tracheal tug? Accessory muscle. Which is the accessory muscle? I will never know. Okay, so there's tracheal tug. There were rib recessions. There were sub and suprasternal recessions. There was little tiny bit of nasal flare there. And did you see the minute movements of the head? Do you get what I mean by it's underwhelming? There's also a little bit of grunting going on. Yeah, very wet baby, that one. Yeah, so that one was a very sick child, so hopefully you don't get anything like that. Just pop your hands up. What resources might you use if you've got a very sick baby? Rest rate 66, SATs at 88. Oh, I didn't mention to do their SATs. Please do their SATs, and we usually do that on the right hand and wrist. Because we're looking for something called pre-ductal SATs. We'll talk about that in the next section, but how would you assist that kind of baby? CPAP, absolutely. Give them some positive pressure because they don't have very many alveoli and they need to recruit their alveoli. Anything else? You might want to try high flow first. It depends how floppy your baby is. If it's looking very floppy and having apneas, I would 100% go to either bag valve or PEEP. Anything else? Diesel. All right, go faster. Give them some caffeine, pack them up. I've not heard of using diesel, but I'll have a look at that. Just one thing with our saturations. If you are going to give them some oxygen therapy, start with room air and work your way up to the FiO2. Just because if you start off with 100% FiO2 on a baby that's not in actual active resus, you can do a lot of damage. Oxygen's a free radical. It will damage their cardiac cells at the worst instance, cause arrhythmias, which we don't want. And in other cases, it can cause retinal damage and cause permanent blindness. So careful on the oxygen. We can also use repositioning and small and frequent feeds as well. Okie doke. We've just got our blood pressure and heart rate next. So our normal ranges, so 60 to 90 systolic and 20 to 60 diastolic. And the rate of heartbeats per minute is usually 120 to 160. The cap refill should be under 3 seconds. So if it's 4 or more, it is quite concerning. They have a lower blood pressure because there's less space to go to. They've also relied on mum's circulation for all that time in utero when they were just having a good time in a cushy waterbed. And their left heart isn't used to pumping to the entirety of the body. It's not yet thickened. We do the SATs on the right hand. I don't know if you can see this lovely ductus arteriosus. But if you are measuring the saturations on the right hand, it's also what's going to the brain. So you get an idea of brain saturations. And the ones that are past the ductus arteriosus are going to the gut and to the lower limbs. So a difference of about 3% in SATs can indicate a patency that is too patent in the ductus arteriosus. And we don't necessarily want that. The cells should be dividing and closing that up very quickly after birth. What we want to avoid is shock in our neonates, because shock is the mismatch of oxygen supply and demand, and the neonates deteriorate very, very quickly when they are shocked. So it starts within the first few breaths, so the processes start. It should be closing slowly, slowly, slowly. Some people will have a patency forever and never know it because it's very small. But sometimes if it's a big one, they tend to have a collapse around days 3 to 5. And they'll start off with poor feeding and lethargy, always a non-specific symptom, and then collapse. So effectively, it needs to be increasing over those few days. Thank you. Good question. Complicated. So some people get different medications like prostaglandins and things to help to close it, but with your positive pressure, I'd have to have a much closer look at other things to close that ductus arteriosus. Normally they come to us and then they go elsewhere. When the oxygen is stimulating, breathing, all of those things. With the alveoli and things, but again, I would have to have another close look. But I'd be interested, and I'll get back to you at some point if I can find that information very quickly. All right, so we're talking about shock at the moment because babies, especially septic babies, will be deteriorating when they are shocked. So very quickly, any strategies that you guys might have if we are looking at a blood pressure of 60 on 20, a heart rate of 200, and a cap refill of 4 seconds. Just have a 10-second chat, anything. 5 minutes?
And then when you're done, if you're right to pass the mic and click us straight to Amy, that will talk in between, but
Yeah.
it'll be a quick switch.
Okay, guys, what have you got? Let's have a chat very quickly. Does anyone want to volunteer what they might do for this baby? A fluid bolus, absolutely. So our paediatric life support guidelines and our stable guidelines are telling us to start with 10 mils per kilo, and we continue giving 2 to 3 boluses before we move on to inotropes. So we want to bring up that blood flowing and the oxygen delivery to all of the tissues because sepsis is a distributive shock. So the fluid's not going to where it needs to be, and we want to get it back into that vascular space. Any other things you might want to do? of the glucose separately. So if you've got a problem with sugar, fix the sugar. If you've got a problem with heart rate, cap refill, and blood pressure, fix that as well. So it's not so much an alternation, it's a fix it as it's broken. Yeah. Pardon? Absolutely antibiotics, but we're going to move on to the next slide because it's related. Thank you for saying antibiotics. We are going to look at lab work, so we might look at the inflammatory markers. So most people will do full bloods, urea electrolytes. We will do cultures and potentially do urine and lumbar puncture as well to do cerebrospinal fluid culturing, as well as to see the makeup of that. Neonates should have an increasing white cell count from the day they are born, and anything under 5,000 is quite concerning. It's really important that white cell count goes up. If we've just got a lovely made-up arterial gas, I know you can see a capillary gas happening, but the guidelines in Stable actually say not to rely on capillary gas when you're using a ventilator because it's not as accurate as arterial and venous, so just sort of thing. So our pH is 7.3. Normally it's 7.35 to 7.45. CO2 is 48. We want that to be 35 to 45. Oxygen's 78, very low. Sats are 86, also very low. Bicarb's 24, so that's within range. And our lactate is 4.2. With neonates, a lactate of 4 or more is very concerning. So I heard someone say earlier what you're going to give them. Say it again, please. Yes, antibiotics, absolutely. So we usually cover for bacterial and for viral as well. So generally some broad-spectrum antibiotics, depending on what area you're in. Australia is one of those places that has a lot of microclimates. So the type of antibiotic you use really depends on which section of Australia you're in. So look for your local guideline. We're moving very briefly onto our emotional support in the interest of time. So really there's a few different people involved here. We've got the infant, we've got the family and caregivers, other staff members and yourself. So strategies that we can use to minimise distress for our infant is to do things like cluster care. We can reduce the stimulus for sound and for visual, so dim the lights. And we can also make sure that baby's got parents or family around them, or a stinky shirt that's been worn for a couple of days, so familiar smell. For family and caregivers, any strategies you might want to implement? Keep them involved, yeah. Tell them information. Anything else? Social work, yeah. Normally we would try and keep a support person with them to explain everything that's happening as well. Other people to consider are other staff members and also yourself. Does anyone have like a post-work routine or a debriefing routine, anything like that? Yeah? Anyone want to share? Yeah. I was going to say you can get together with your colleagues and talk about your alcoholism, but... Hot debrief, yeah. It's one of the best ways to actually process things, and reflective practice is another one of them. But it's also important to look after your body as well. So, you know, doing exercise more than just lifting the alcohol to your mouth. And also, you know, eating well, all of those things, trying to get some sleep if you ever can. It doesn't happen when you've got shift work. So if your parents are outside looking blank and you've got a colleague tearing up, anything you might want to implement there? A hug? Yeah. Not everyone's a hugger though. So pat on the back, yeah, okay. Yeah, I think sometimes when we say, are you okay, that makes the flood works start. So potentially taking them aside and making sure they're okay outside of the bay, stay a little bit professional, have your emotional response after the fact. Yep, anything else? Yeah, sit with the parents and comfort them and explain everything, because health literacy in Australia is pretty poor. I don't know about other places, but most people don't know what people are doing. Get them to take some photos, videos, change nappies, all of those things that they might need to do. They are experiencing grief and trauma, and they might have things that are really important to them, like having a milk plan or getting to make sure that they're pumping and things like that. Okay. Go back one time. So using the strategies that we've talked about, we have decided that we have stabilised our little Spudley here. So are there any final questions that are less complicated? Okay, thank you very much, everyone. You've just reviewed stable.
Brilliant. Thank you so much, Tash. That was an excellent way to kick things off this morning. Wish we could give you more time, but there's always future conferences, so we'd love to have you back for that one. So, no time to rest. We're going to kick on straight to the next presentation. It's another past attendee, so let's make Amy feel really welcome as she comes up to stage.
Another difficult act to follow, so thank you, Tash, that was fantastic. Hello, everybody. So my name's Amy Rolston. I am a Perth-based emergency registrar, and I actually work at the same hospital as Tash, so anytime a neonate comes in, she will be in my speed dial to get you on board. The topic that I'm presenting today is the imposter phenomenon. So I have been a long, multiple attendee, but first-time presenter. The other conferences that I've been at have been evening conferences where the wine has been flowing. So I will caveat that there is a drinking game in my presentation. Feel free to reach for your hip flask, or just go with it. So the goals for this presentation are essentially to inform, so I want to give you guys some facts, some figures, and to dispel some myths as well. And essentially to arm you going forward for yourselves and for the people you work with in your departments on how to actually approach and deal with imposterism and what it looks like. And then lastly, for myself, I want to just be that drop like somebody was for me a long time ago that creates some ripples and makes you think, and maybe you bring some of these concepts forwards and discuss them, and it helps somebody and makes everybody's brains a slightly nicer place to live in. So you're going to have to indulge me a little bit and trust me for a second, because we're going to do a little exercise, my very own scientific experiment. I'm going to get you guys to close your eyes. Okay, so this is a blinded study. No decimal points, no. So close your eyes, and I just want you to put your hand in the air if you have ever heard the terms imposter syndrome, imposter phenomenon, imposterism, the imposter experience, fraud syndrome is another term it's known as, and talent dysmorphia. So keep your hands up if you've ever heard of any of those. All right. Keep your hands in the air with your eyes closed if you've ever experienced what you understand to be any of those feelings. You can drop your hands and open your eyes. Thank you. My conclusion has been confirmed. Now, when I first heard about imposter syndrome, I was very misinformed, and I thought I was being called delusional and possibly psychotic. So it is not imposter delusion. These are excellent books about imposter delusions, like Capgras syndrome, where you think everybody around you has been replaced by enemies who are trying to trick you and possibly kill you. But great reads, not the topic we're discussing today. I will explain to you what imposter syndrome is. We'll get to it, but first, we're going to play a little game called Never Have I Ever, which, if you went to my university, you will know this game, but possibly you're much more mature than I am, and you've not played it. If you've not played it, when you have done the Never Have I Ever, you have to drink. So if you've got coffee, you're going to be feeling pretty jittery by the end. Okay, so the first Never Have I Ever. Never have I ever been in a situation where a member of my team has been regaling this high-stakes story of the really difficult resus where the neonate came in and they needed all of these things, or it was a head trauma with a GCS of 10 and they needed to be intubated within minutes, and you had to plan your intubation and your drugs, and wow, you're sitting back thinking, this person is so clever. God, I would never have thought of like step 2 or step 3, and they just know all of this. I'm supposed to know all of this. Shit, I don't. I'm such a fraud. Why am I not able to be the anaesthetist and be the physician and be the surgeon all at once and the neonatologist? Never have I ever, I'm going to stand back so people can see that, worked in an understaffed environment. Okay, I'll paint the scene. You're working in an understaffed environment. Lots of people have called in sick. Your patient load is huge. You're looking after 10 conflicting priorities all at once, and you're like, okay, I'm not on top of things. And then you've got to hand over a patient, and you're like, God, this is so undercooked. I'm so sorry. This is bad. They've had antibiotics. That's basically it. And inside you're thinking, this person's going to know that I can't do this, that I'm just really bad at my job. And you're also thinking, why did I bother? Like, if I couldn't do this well, then just, Okay. Never have I ever been in a room where you're being asked, you're being picked out to answer a question, and you're going, I don't know this topic. I really hope I don't get asked. Just ground, please. Just open up and swallow me up. Just don't see me. I'm not here. I'm invisible. I don't want to be asked. Or you get asked, and you get the question right. And you go, that was an easy one. Everybody knew that one. Yeah, I don't know. I don't know anything. Or you get it wrong, and then you go, see, I didn't know it. I don't know. Everybody else would have known it, though. Never have I ever actually done something pretty remarkable. Gone for the job, prepared exceptionally well, and actually gotten the thing, achieved the thing. Maybe it was your degree, maybe it's the job that you didn't think you'd get. And then after getting the degree or the job, you go, I got really lucky, didn't I? Actually, I knew somebody on the panel and they just must have put in a good word. Or nobody else applied for that job. Actually, I was the only applicant, probably. Or there was a clerical error and they gave me the degree by accident. Whoops, I'm a doctor. Or maybe you just never applied in the first place because you probably wouldn't get it anyway and you just don't want to fail. If you answered yes to any of those questions, you probably have some features of the imposter syndrome, okay? Of imposterism. So what it is, you're not psychotic. It is a perceived intellectual fraudulence with that fear of exposure, the feeling of being a fraud and people are going to find out. Even though there's objective evidence to suggest that that's not true, usually there's a decent body of evidence to suggest it's not the case. You fail to internalize any of your accomplishments because you put them down to external factors, and you discount and you diminish your capabilities and achievements. So, yeah, I mean, everybody can do that, right? And instead, you say, oh, it's because of other people. It's because of luck. I've had a lot of help along the way. And then any setbacks, any failures, inevitable failures, because we all don't win at everything all of the time, are utilized to further support your theory of I'm a fraud and actually completely inadequate. It was first kind of described as a phenomenon in the 70s by an American psychologist who made a big list of about 20 questions, but it basically boils down to having around 2 of these 6 things. Feeling that you should be a superhero. I should have the hat of the anaesthetist and the physician and the surgeon and the radiologist, and I should be excellent at all of those things. Do it better than anybody else. I should be special and the best at the thing. This is not like in a big-headed way. It's like, oh, if somebody is able to teach me anything about an ECG, I know nothing about cardiology. Like I shouldn't be in this role because I don't know everything there is to know. The fear of failure, the anxiety of actually just starting something because what if it goes wrong? What if I don't get to complete it? And then denying ability, the well done, you did really well. Nah, that was luck. Feeling of fear and guilt about your success. So once you get that job, once you get the role that you work really hard for and actually you're really qualified for, you kind of go, I can't do this. Why did I ever think that I could do this? So you fear actually your successes. And then the presence of the imposter cycle, which looks a little bit like this. So initially, I can't achieve it. I just doubt my ability. So in order to achieve goals, I'm just going to set ridiculous expectations that I would hold nobody else to, actually. But these are the goals that I'm going to set for myself. And then I'm going to feel really anxious because that's a really unachievable goal, actually, but I'm going to feel awful about it. And also, maybe everybody else is looking at me and thinks that I'm not able to do it as well. Everybody else knows. So this high goal is set, and you work really, really hard. You pull extra hours. You stay up late. Cancel the gym. I won't do meal prep this week. I'm going to cancel that date night, and maybe I won't see my friends because I need extra time to get this thing that everybody else could do in 5 minutes. And you over-prepare and inevitably succeed because you've done all of the over-preparation. Or maybe you procrastinate because you put it off and you fear failing, and then you do it the night before and actually you pull out something excellent because you pull an all-nighter, and then after you succeed, you go, oh, I didn't deserve that because I did an all-nighter and I really underprepared. So you don't internalize it, you're still an imposter, but now you're a higher achieving imposter that doesn't deserve what you've achieved. And the cycle continues. So it is just repeated successes that unfortunately propagate more cycles, and it doesn't break as you grow, as you get better. And the inevitable increased achievement initially, because of this cycle, means that the pressures are growing and you have more responsibilities now. And then with each cycle, you reinforce that cognitive cycle, that neural pathway that says, oh God, I'm actually a fraud. And if you fail at any point along the way, see, I couldn't do it. I wasn't able. And it validates that belief. There is some good news. It's not all doom and gloom. So after my very scientific study at the beginning, I can confirm that you're not alone. You're not the only person who is experiencing these feelings. By definition, thinking that you're not the best at everything, you're not a narcissist, which is always good to know. And also, you're in very, very good company. So some of the greatest minds of all time have expressed these imposter feelings. The Einsteins, Tom Hanks, David Bowie. We learned together yesterday that statistics mean absolutely nothing, but apparently somewhere between 70 to 90%. So initial study said 70%, but probably more like 90% of us in healthcare will at some point experience these feelings. So this is Einstein, who describes himself as an involuntary swindler, whose work didn't deserve as much attention as it had received. As in relativity Einstein. Basically all of our modern day aeronautical science based on his theories. Imagine if he had just thought, oh, that's a crap idea and everybody else will think I'm an idiot if I say that. And it just kept it to himself. So we can thank him for GPS. I think a lot of us would be bumbling around Old Town if it wasn't for Einstein. I wouldn't have made it here. We're not all the same, we're all different. So imposterism can be separated into different types. You don't have to be exactly one, you can be a bit of multiple, but you might be the perfectionist where any flaw is, nah, why did I even bother? I didn't get it 100% right, so it's crap. The expert, so it's not about the body of knowledge that I do know. If there's anything I don't know, then I'm not good enough to have this job. The soloist, so I think this happens a lot, and it's really not suited, like it's counterintuitive in the emergency medicine space to be, I can do this by myself. And if I ask for help, if I have to ask for help, God, that's a bit of a, I should be able, everybody else is able to do this by themselves. The natural genius. I've had 3 piano lessons and I'm not playing Beethoven yet. Why is this so hard? I should be able to do it. And the superhuman, who we've mentioned before, but I should be able to have all of the hats on. I don't expect anybody else to be able to do that, but I should be excellent at everything. What it is not. So it's not in fact a true syndrome, and calling it that is sort of degrading it a little bit because it's a universal experience. It makes it an isolated entity. It's not abnormal, it's not a malfunction, which means because it's not something that you can put a label and put in a box, there's no DSM-5 criteria for this. It's not an ingrained part of our psychology, so you can't take it and say, oh, I've got imposter syndrome, I just need extra time on the exam. I just have to work around it, so I do have to work harder and longer hours to do the same, because not everybody has this. Sorry, no. It is therefore not unchangeable, so there is a way to address it, to recognize it, and to work through it. This book has already been touted yesterday, but there is a concept in it that I really want to get across because it's really important to how we actually address imposterism. So it's the fast thinking and the slow thinking. The instant, I see a bear, I run from the bear, versus the slow processing. I see a bear, wait, I'm at a zoo. I don't need to run from the bear. Okay? My favorite way of thinking of it is when you get in the car and you're leaving work and you're driving home, at some point your body just takes over, your brain takes over, and you're home, and you don't really remember all the steps that it took to get there. Yeah. But then you move house, and you get in the car and you're halfway home, and you go, oh shit, I don't live there anymore. So you got to pull over, open up GPS, thank you Einstein, and pop in your little, okay, new house, new route. So it's rerouting. It's stopping, recognizing, the spiral thing. Maybe I need to reroute and rethink how I'm going about this task. Few myths just to dispel, because I think that everybody often thinks of imposter syndrome as something that predominantly affects females in high-achieving environments. Younger people are more likely to be affected, and usually there's underlying anxiety, depression, mental health illness. Because of the nature of the initial studies and research around this, it was in the 70s, it was run by psychologists, so people being incorporated into these studies were already engaging in psychology services, were females in university in the 70s. So there's an awful lot of skew in the data, and more recent research, though we don't trust research anymore, is that it can affect any sex, it can affect any race, age, occupation, skill level. It doesn't matter whether you're a neuroscientist or what you are doing. There may be a disproportionate number of people who are, say, underrepresented in their fields who experience it, which probably goes back to the, if I can't see it, I can't be it. Nobody here looks like me. Why do I think that I can do this when nobody else like me is doing it? We are a little breeding ground for imposters in emergency medicine. So things that we have that contribute, policies and practices, essentially that make individuals feel like they're stupid, they're questioning their decisions, questioning their intelligence and their competence, or maybe that they don't belong in that space. We have, this list is essentially endless, but this is just some examples from our workspaces that represent contributing factors towards propagating imposterism. We're inconsistent by the nature of the work that we do. We work with different people all of the time, and the people who we're working with and we're reporting to will have different standards about what the gold standard of treatment is for this pathology. We're variably supervised, depending who we're working with on that shift, what time of day, is it night, is it day? I have lots of autonomy. I'm not allowed to make any decisions at all. Should I be making decisions ever? Feedback can often be arbitrary, like several months go by before you actually get some feedback, and then it's like, yeah, you're doing really well. Thank you. Nobody's complained about you. Is that enough? And then, so opportunities. Depending who you vibe with on your shift, are you going to be told, oh, there's this thing coming in, why don't you do that? And I'll watch you and I'll give you some feedback. Or the nature of working in a shift. If you're not a magnet, then maybe you don't see all of the really scary things all of the time. And if you are, you get exposure to lots of different things. We work in very time-constrained environments, and what we do is critical and high stakes. So not always the ideal spot to go, is there an alternative way of managing this arrest? Maybe just park that. So the nature of that is that feedback and questions are not always appropriate at that time. And then the role switching, the constant role switching. We expect ourselves to be able to do everything to manage the neonate and the pregnant lady and the 95-year-old who's had a fall. And you don't always have time to gather yourself before you're the next version of you. I think most departments are getting better in regards to the culture and policies around error and blame culture and M&Ms that are actually not a scary place to be, but they can be. And uncertainty. I don't think we're ever going to work in emergency medicine and have certainty. Our patients are by nature undifferentiated. So if you tell, the imposter who thinks they have to know everything about everything that you're not going to be certain, that's a problem. I love a new concept. So, so we work in imposter factories. We work in poop factories. Pluralistic ignorance concept. It sounds, anyway, essentially, I really enjoyed learning about this. You know when you know something exists but you haven't got nice words for it? This is the nice words. Where a group individually is privately rejecting something that is considered normal, but publicly they're going along with it because everybody else is going along with it and they think that they have accepted it. So they're like, okay, yeah, this is normal. Picture, okay, I'm looking after 10 patients. I haven't peed in 7 hours, haven't eaten anything. I don't know what to do with that one or that one. There's standing room only in the waiting room, and 27 ambos are lined up, and they haven't had their breaks. And I'm really trying to make decisions, but everybody else looks fine. So I should be fine. This is normal. Carry on. Nobody else knows what your internal experience is, and similarly, the converse is true. So why is it important? Why am I bothering to make you sit through me chatting for the day and playing my drinking games? It has impact on you. It has impact on your workplace. It has impact on your friends and your family. That may not be obvious to begin with, and it has impacts on your department and your colleagues. So, by nature, we're very good at facilitating things. As humans, we just mold, we go with the flow, we change, we adapt, and that's how we survive. Imposters survive by flying under the radar. If I don't ask if I'm doing okay, I'll be fine. Nobody will know that I'm a fraud. Procrastinate. I'll just put it off, and then maybe I'll have a brainwave. I'll work extra hard, harder than anybody else. I'll cut off my family and friends. Who needs a social life or exercise? Ready meals are the way to go. Or actually, I just won't put up my hand, and maybe then I'll just be able to get by. And I won't go for that thing because I probably, I'm not qualified for it anyway, and they'll just laugh. The result of these things that we think we're doing to help ourselves, to facilitate our imposters, are that we don't want to go to work because work is stressful and it's hard and everybody else looks like they're fine, but then I'm isolated with my dirty little secrets that maybe I don't know. And you inevitably get burnt out because it's just not a cycle that is sustainable. And you miss opportunities. So this is another book plug. I actually have quite a few book plugs in here, sorry. But always love a good recommendation. So Malcolm Gladwell in this, I won't go too far into it, but presents lots of ideas. But one of them is this idea of cumulative disadvantage or advantage. Basically, in Canadian ice hockey, stay with me, the school cut-off age is the 1st of January. And when they look at professional Canadian ice hockey players, there's a disproportionate number who have birthdays in January, February, March. So if I go to school and I'm born on the 2nd of January, I wait and I go to school, say, in September. But if I'm born on the 29th of December, then I'm also in that year, right? So the cutoff is the start of January. I've got to wait an extra year. So when I go to school, I'm 4, and I've got 25% more brains. I'm more coordinated, I'm bigger, I'm smarter. And when we go out for sports, I get picked for the A team because I'm bigger, better, and stronger and smarter. And then I'm on the A team, so I get more team time, I get more training time, and I get better coaches. And then the next year, I'm way better. And that propagates and is a cycle. And by the time you get to adulthood and you look at professional sports players, the proportion born in January, February, March, because from the get-go they've had all of this advantage, is much greater than those born in the last few months of the year. Anyway, that was a bit of a tangent, but interesting. The same is true, though, for not putting up your hand. So if I don't put up my hand, I don't get that job. And then the next job comes up, and because I didn't do that job, I don't get the next job because I'm not qualified for that. So there's also that negative cumulative disadvantage. What does it look like for this? Again, is a list that could be endless. So the answer is not good, is how it looks for your department. And ultimately, it's detrimental to the safety of patients and staff and detrimental to the efficiency of your department. But patients, so if I'm questioning everything and I can't decide what to do, I will over-investigate or I will put off making a decision, and then flow through the department is also going to be impacted. If it's a resus situation and I have an idea, but I think that my ideas are stupid, I'm not going to put my hand up and say, have we thought of this? Training, so if I can get through training without putting up my hand and getting assessed and saying, actually, I want to put in this line or I want to do this, can you watch me and give me feedback? Because we don't want to be assessed. Then by the end of training, we've just got a much poorer skilled workforce. And then the inevitable effects on your well-being, on burnout for the person, but also for the rest of the team. So more sick calls, worse workplace, and more understaffing. And then the issue with wasted talent. Actually, I'm Einstein and I've got an idea, but maybe I just won't tell anybody about it. I'm sure Einstein is in the crowd somewhere. What can we do? So this is, the 3 C's is a concept that is very popular within, it is essentially what cognitive behavioral therapy is based on and used frequently, but it's the catch, check, change checklist. Catch it. So, you're in the resus and you're spiraling and you're going, oh my God, I don't know. You need to recognize that it's actually happening, that you're driving to the wrong house in order to change direction. So you want to listen and just say, okay, is this logical? Is this nasty? I was told to name the voice, and that's a bit of an out there thought, but just go with it. So mine is Judy the jerk. Definitely not based on a real life Judy. She was a jerk. Check it. So you've stopped, you've said, okay, that's actually a bit of a disordered way of thinking maybe, but also maybe I can't do this task, so I'll just check logically, can I not do this? And the 2 questions to ask yourself is, who do you think you're kidding? Like, I'm going to wager that a lot of people you work with are very intelligent. They're actually pretty clever. So give them that benefit of the doubt. If somebody comes up to you at the end of a shift and says, they come and find you and say, thank you, you did a really good job and I actually really appreciated, having your support in XYZ. Do you say, you don't know what good work looks like? If that's your idea of an organized person, you need to, really reevaluate, buddy. You probably say thank you. And the chances are they haven't come and sought you out, not believing what they are telling you. And also, do you really think that the clever people you work with, if you were disastrous and if you were in fact dangerous and all of the things Judy Jerk is telling you, do you think that they wouldn't have flagged it and you wouldn't be getting assistance, like additional help? So just have a bit of faith in your colleagues as well. And then who do you think you're talking to? As in, like, who do you think you're talking to, Judy? This is another kind of take that voice outside your body situation. If Judy was there and saying the things she's saying to you, to your best friend or to a child, all right, so your kids, your nieces, your nephews, Billy's there working really hard to colour in between the lines. And the blue goes out over the line. And Billy's like, oh, damn, but he keeps going. And Judy goes, Billy, that's crap, actually. You can't colour. You're really bad at colouring. You should probably stop trying. You would kind of go, excuse me, it sounds ridiculous, but it's what's happening on the inside. So just kind of take a minute and see, is this logical? And then change it. So this is the reframe. So this is what we're going to do. Once we've checked, we've recognized, we've named it, it's not logical. Okay, we've pulled over and we're planning. So we're reframing. Neuroplasticity, so essentially just this concept that we can stop and move from the well-trodden path to a different path. It is not easy, but with practice it gets easier. So only you know when your imposter strikes. So know when that is and have something in your head. So if it is the resus, there's so many resources for different things in ED, but say it's the resus and when you get overwhelmed, you think I can't do it. So use something like the Beat the Stress Fool. I don't know, has anybody seen this, but it's just an approach to essentially managing your anxiety in a resus situation. It's pretty popular. But lots of examples in the FOMED space. So this is the breathe, talk. So this is what's happening. This is the major issues, the life threats. The see and visualize. So what are the life threats that we need to address? This is what needs to happen. And then focus. If you say it out loud, this focuses your team. So that's that concept. But again, when your imposter strikes, there will be different approaches. This is my dog. Her name is Goose. It is the ultimate imposter. She's a very good dog, and she has gotten over her imposter syndrome. This was her studying for her primaries. She didn't think that she could do it, but she got there. So I know you're like, okay, cool, is your answer just think different thoughts? Thanks, Amy. But what I'm saying is think like a non-imposter. So stop being the perfectionist. Stop being unrealistic and become pragmatic and realistic. And that means getting pretty uncomfortable with some of these concepts. You are wrong. You are going to fail. You're not perfect. And you can't be the best at everything. And you need help. These are some truths that you probably accept for everybody else, but maybe not for you if you suffer from a bit of imposterism. And then, reframe. So this is just switching out those thoughts. So once you've done your 3 C's, this is the reframe and how to just think differently. Because you're going to experience uncertainty, okay? But instead of it being, if I have a mistake, that's going to be a personal failure, you're going to go from being fixed failure mindset to a growth mindset. So actually, mistakes are inevitable, and that's how I learn. Because If I wasn't learning, if I was already the best, A, I'd be a narcissist, and B, I'd have nowhere to go, and life would be pretty boring. So some common reframes. So it's not a failure. Actually, I'm just learning. I'm not stuck. I just need to rethink this and get a bit more creative, maybe approach this problem differently. I'm not lost. I'm exploring. And GPS is like, I've lost signal. I'm not stupid. I'm just a human, and actually this is part of growing and learning from everybody else. Famous reframe is the Edison. I haven't failed 10,000 times to make a light bulb, but I've just found 10,000 ways of not making a light bulb. And then my favorite ever reframe is, so Daniel Boone was one of the original explorers, 17th, 18th century American guy. He probably didn't look like this. But he said, I want to get this right, he said, I have never been lost, but I was befuddled for 3 days once. Ultimate reframe. So that's how to help you. We want to help others, okay, as well. This is some concepts that I've picked up along the way, but also things that were taught to me. So on that first day when I was presented the imposter syndrome as a RMO stepping up to a registrar, I was told, go first. So just be brave and be the person who says, oh God, I actually don't think that I can do this. And I'm really struggling, but that's my imposterism and I know that I can, and that's normal. So normalize that feeling and say it out loud. Lift as you climb. So just don't forget, I think because we're so in our own experience that we forget that 2 years ago, we really struggled with that thing. Or even a week ago, something that we can now do fairly easily, and it's fast thinking. Somebody else is really struggling. So say out loud, it is normal to ask for help, and if you're not asking for help, it's actually pretty worrying. We don't expect you to know everything, and actually if you think you know everything, that's pretty concerning. ED, emergency medicine, is a team sport, so don't hug the ball, please ask for help. You are smart, you can do this, you just aren't an octopus, so you can't do 8 things all at once. And then the F-up friend, this was another thing that was, sounds a bit out there, but if you pick somebody, it doesn't have to be a colleague who is in medicine, it can be a friend, a family member. Their role is to hear, not to give advice. So this is the person that's kind of your safe space. And you can say, I think I fucked up, made a mistake, I don't know if there's going to be major consequences. Maybe nothing happened, but something awful could have happened. But externalize it so that it doesn't stay on the inside and become that dirty little secret that becomes guilty and then just adds to your little collection of dirty little secrets that support your imposterism. So, yeah, lift as you climb and have an F-up friend. This is Goose's new little brother. Yeah, his name's Wally. Anyway, so thank you for coming on this journey with me. Take home points. So I'm sorry, it is not something that you will overcome. You can't beat imposter syndrome. But you can reframe, and it's hard, but it gets easier because you just need to create new neural pathways. It is an experience, not a pathology, so don't give it space. Don't work around it, and don't adapt to it. 3 C's, catch, check, change. Put your name in the hat, put your hand up, apply to speak at the scary conference. Think like a non-imposter, be realistic, be a pragmatist, and start that habit. So once it becomes a habit, you can, instead of having an imposter life, maybe just have an imposter moment now and again. And don't forget to lift as you climb. Thank you.
Thank you so much, Amy. And once again, so many awesome points there. So please don't hesitate to have a chat to Amy, or I'll dob Tash in as well if you do have any questions. And we do have the recording of all these presentations. So especially those take-home points, definitely good ones. Let's take a break. We're going to be starting up here just before 11. So about 10-ish, 12 minutes. Stretch the legs, grab some food, and we'll see you soon. It looks like we have a full room, so we will get started. Air conditioning. It sounded like it was a little bit cold in the room, so I have turned it up. I could only turn up 4 out of the 6 vents, so if you feel some really cold air blowing on you, apologies, you might just need to swap a chair. So hopefully at least 2/3 of the room should be perfect temperature now. Prize Bonanza Day today. We've got 3 shirts to give away, a bunch of passport wallets, so thank you everyone for submitting your photos of the day. For those that are new to the EMS conferences, it's a very technical way that we decide who wins a shirt. It's the loudest cheer in the room. So if you see a photo that you like, nice polite clap. If you love it, let's hear a cheer. And I think we have about maybe 10-ish photos, so let's get started. Oh, look at that. Show me a better study view. What do you reckon? Oh. Animals and babies always get the prizes. Oh, here we go. Not bad at all. Oh, a bit of a collage. These are some good photos. Oh, Brendan. Bit of AI. All right, so far I reckon we have this one and the kitten are the 2. Still 2 more to go. Oh, that's like out of a guidebook. That's really impressive, whoever took that. That's getting a t-shirt. And final one. Oh, that's nice. All right. Everyone who submitted a photo, come see us, or come see Max at the end of the sessions. We'll all get a EMS passport wallet, and then let's go the amazing train track photo, AI image, and the kitten for our winners of the day. Round of applause to everyone. We've also potentially got another very special prize. We had a lost phone handed in. If you've lost your phone, let us know. Otherwise, tomorrow, guess what? Loudest cheer gets a phone. So we do have that up the front. So I think we've got the poor person. Don't worry, we won't point you out or anything like that. Really excited for this next presentation. So a lot of the feedback we get from our conferences, because we are sort of travelling so many different places, is about wanting to understand a little bit more about what's happening locally, what do the ambulances look like. In Bali, we're able to have hospital tours, which are really exciting. And thanks to Eb for an amazing contact, we've actually been able to get one of the medical directors from Danang Hospital, Dr. Thao. And please give her a nice warm round of applause as she comes up to the stage. Thank you, Dr. Thao.
My name is Thao. Tôi là người Việt Nam. Tôi sống tại Đà Nẵng 50 năm, giống như tuổi của tôi.
She would like to introduce herself. Her name is Thao, and
Sống tại Đà Nẵng.
she has been living in Da Nang for 35 years.
Tôi làm việc tại hệ thống cấp cứu 30 năm.
And she works for the emergency for 30 years.
Hôm nay cũng rất là vui và chào mừng tất cả mọi người đã đến với thành phố Đà Nẵng xinh đẹp, giống như Mr. Queen đã giới thiệu.
And today she's really excited to welcome you all to her beautiful city, Da Nang.
Tôi cũng rất là hy vọng là mọi người sẽ có một cái sự trải nghiệm rất là thú vị tại Đà Nẵng và Việt Nam.
And she also hoped that you all can experience Đà Nẵng and Hội An during your stay here with us.
Và tôi cũng rất là cảm ơn Miss Queen đã cho tôi một cái cơ hội để tham dự một cái hội nghị mà có nhiều cái điều rất là thú vị. Và tôi cũng muốn qua cái hội nghị này cũng giới thiệu về cái hệ thống y tế cấp cứu ngoại viện EMS của Việt Nam và đặc biệt là thành phố Đà Nẵng.
And Miss Thao is really thankful for Mr. Quinn for inviting her, and she's really excited to introduce the health and also the emergency instructor in Đà Nẵng for you all.
Tất nhiên là khi tham dự cái hội nghị này tôi có một chút vấn đề, đó là tiếng Anh của tôi nó không được tốt và tôi cũng đã nhờ sự hỗ trợ và hôm nay cũng rất là cảm ơn khách sạn đã hỗ trợ tôi để tôi có thể trình bày tất cả những cái nội dung tôi muốn trình bày đến với các bạn.
She said, of course, her English is not good, so please excuse her, and that's why I'm here to help her today.
Và tôi cũng hy vọng là những cái nội dung tôi muốn chia sẻ với các bạn cũng sẽ làm cho các bạn không cảm thấy là mình quá nhàm chán và buồn ngủ.
And she hoped that the details and everything she's gonna share will not be too boring for you all.
Và để khích lệ thì cũng mong muốn các bạn cho tôi một tràng vỗ tay để tôi có thể có động lực để tôi trình bày những cái nội dung tôi muốn gửi đến các bạn.
Can we please give her a please excuse my English as well.
Hôm nay tôi cũng muốn giới thiệu về thành phố Đà Nẵng năm 2026. Năm 2025 rất là khác so với năm 2026. Một vấn đề là hai cái thành phố, hai cái tỉnh là Đà Nẵng và Quảng Nam. Mà Quảng Nam trong đó có cái Hội An sát nhập lại làm một.
So 2025, it was a bit different compared to 2026 because last year, Da Nang and Hoi An was two different cities. We were in Quảng Nam province and Da Nang was a city on its own. But this year, the government had decided to merge the two cities together, include the whole Quảng Nam province. So now we all Da Nang city.
Với một cái diện tích sau khi tới năm 2026 đó là diện tích gấp 6 lần của thành phố Đà Nẵng và dân số diện tích gấp 11 lần và dân số gấp 6 lần. Với một con số ở trên màn hình các bạn có thể nhìn.
The population and the size is different, and you can have a look at the numbers on the slide here.
Đối với cái thành phố Đà Nẵng cũ về cái hệ thống cấp cứu thì chúng ta có 9 cái trạm cấp cứu để thực hiện cái nhiệm vụ cấp cứu của người dân bố trí tại khu vực Đà Nẵng cũ.
And in the old Da Nang city, there were 9 community health station.
Với một cái khoảng cách thời gian tiếp cận rất là ngắn thì chúng tôi tiếp cận khoảng 10 phút từ khi tiếp nhận cuộc gọi cho tới khi mà gặp được người bệnh là trong khoảng 10 phút. Đây là một cái vấn đề rất là thuận lợi cho cái hệ thống y tế tại thành phố Đà Nẵng.
So usually it takes about 5 minutes after receiving the call to be able to get close to the patient.
Sau khi sát nhập với Quảng Nam thì có cái địa hình rất là đặc thù là khoảng cách địa lý rất là xa và đồng bằng kể cả miền núi và kể cả vùng núi cao nên cái này rất là khó khăn.
And after 2026, it's been a challenge because in Quảng Nam province there are more high mountains and the traffic is a bit difficult.
Thì đây là một cái sơ đồ của cái hệ thống cấp cứu ngoại viện tại thành phố Đà Nẵng và cái màu đỏ phía trên đó là cái số điện thoại 115 là giống như ở Mỹ chúng ta có 911.
Just like America, they've got 911. In Vietnam, we've got 115 is our emergency number.
Và chúng ta sẽ có tất cả những cái trạm, 9 trạm cấp cứu, và chúng tôi sẽ điều phối từ khi tiếp nhận cuộc gọi cho tới các trạm này để tiếp cận người bệnh một cách nhanh nhất.
Yep. So these are the names of our 9 community health stations in Danang.
Và cái khả năng của chúng tôi làm được đó là trong một năm chúng tôi tiếp nhận khoảng 23.854 cuộc gọi yêu cầu của người dân liên quan đến các vấn đề y tế.
In one year, we received 23,854 calls from Da Nang and Quảng Nam province.
Và cái tỷ lệ đáp ứng của chúng tôi đạt là 98,8% so với cái cuộc gọi yêu cầu.
98% is the number that we usually can respond.
Yeah. Và cái thời gian tiếp cận điều phối trung bình là từ khi chúng tôi nhận cuộc gọi và tới khi chúng tôi tiếp cận được người bệnh là 60.
60 seconds is the time since we receive and we.
Cái âm gì cái này. Chín trạm. Tí nữa mình sẽ có những cái kế hoạch mở rộng thêm. Sau khi sát nhập thì chúng tôi có 9 trạm. Tại Quảng Nam chúng tôi có Tam Kỳ và Núi Thành. Và chúng tôi cái khả năng mà đáp ứng của tôi là chúng tôi sẽ chuyển dịch một cái trạm tại cái thành phố Đà Nẵng cũ về để tiếp cận tại Hội An, và chúng tôi đang đề xuất để mở rộng thêm một cái trạm ngay tại khu vực Hội An. Đây là cái mà chúng tôi đã xin.
They used to have 9 in only Da Nang city, but then they get rid of some in Da Nang city and moved them to the city in Quảng Nam province. Yeah. And they are trying to have more.
Cái thời gian của chúng tôi tiếp nhận, mà từ khi chúng tôi tiếp nhận cuộc gọi cho tới khi xe cứu thương xuất chạy là khoảng 60 giây, là trong vòng 1 phút.
60 seconds is the time that we receive the call and also we do the average coordination.
Và 52% cái ca cấp cứu tại cái khu vực vùng đô thị, khu vực trung tâm thì chúng tôi tiếp cận hiện trường trong vòng 10 phút.
50% in the main city that we reach out to the patient is usually about 10 minutes.
Và cái khả năng mà chúng tôi thực hiện được trong một năm á, là 77 sự kiện và lễ hội. Ví dụ như sắp đến chúng ta sẽ có một cái lễ hội là Full Ironman. Thì xin hỏi các bạn ở đây có biết về cái sự kiện này sẽ được tổ chức tại Việt Nam hay không, và có ai tham gia hay không? Full Ironman. Full Ironman.
She said that 77 festival and big big events that we did reach out, and also is any of you joining the Phuong Iron Festival that coming soon?
Do you know Full Ironman? Ironman bao gồm là bơi là 3,8 cây, chạy bộ là 42 cây và đạp xe đạp là 180 cây với một vận động viên.
Yeah, it's the kind of like sport festival about swimming, running. Yeah.
Ironman, người sắt. Nên là rất là nhiều cái tổ chức thì họ rất là an tâm và thấy là yên tâm khi là tổ chức cái sự kiện Full Ironman tại thành phố Đà Nẵng. Và thành phố Đà Nẵng là được chọn, trong thành phố Việt Nam, Đà Nẵng được chọn là nơi tổ chức vì rất là nhiều lý do, trong đó có cái hệ thống y tế được đảm bảo an toàn.
Da Nang was the city that chosen for that specific festival because they've got the health structure and everything good enough to have a big event.
Và trong một năm thì chúng tôi đáp ứng được 62 các trường hợp cấp cứu tai nạn giao thông, rất là nhiều bệnh nhân.
And 62 cases that we respond to the continuous traffic issue.
Và chúng tôi có 8 cái ca cấp cứu cho ngư dân đánh bắt ở trên biển.
And we had 8 emergency case for the people on the ocean and the sea.
Và chúng tôi cấp cứu 2 trường hợp nạn nhân ở trên máy bay.
And 2 cases for the patient on the airlines.
I'm sorry. I'm full. Okay. Xin giới thiệu các bạn, đó là cái hệ thống y tế của thành phố Đà Nẵng với những cái điểm mà chúng ta có thể hỗ trợ y tế ở tại thành phố Đà Nẵng. Và những cái chấm màu đỏ là những cái cơ sở y tế mà chúng tôi có thể điều động xe cứu thương và các đội EMS để đến hỗ trợ người dân khi có yêu cầu.
So the red ones on the map are the main health station that we can arrange the ambulance for patients.
Và đối với chúng tôi sắp đến thì chúng tôi sẽ mở rộng ra từ 9 lên thành 13 trạm của bản thân chúng tôi quản lý và sẽ đặt thêm 12 trạm thuộc các bệnh viện.
Now there are 6, but we are tending to expand the stations and wishing to have 13 in total.
Và Hội An là một nơi mà chúng tôi rất là ưu tiên để có thể đặt một cái vị trí và có tất cả các đội y tế và các 2 xe cứu thương để sẵn sàng đáp ứng với một cái mong muốn là khoảng cách chúng tôi tiếp cận là 10 phút khi tiếp nhận cuộc gọi.
Hội An is the main one that they want to have 2 ambulances and also to have all the good health people and everything to be able to be closer to the patient within 10 minutes.
Và chúng tôi sẽ có 12 trạm ở những khu vực miền núi cao và nơi mà cái khả năng đáp ứng thì tôi chưa vươn tới được. Và cái nơi mà rất là ít người ta sinh sống rất là thưa thớt và cái cuộc gọi đó.
And these 12 are smaller at the mountains and the rural area.
Và tất cả những cái trạm này được điều phối bởi một nhận trưởng, đó là Trung tâm cấp cứu thành phố Đà Nẵng với số điện thoại là 115.
And these are all under the control of the health of the Health Emergency Center Đà Nẵng City.
Và đây là một cái hình ảnh mà để mô tả cái thời gian đáp ứng của chúng tôi đang nỗ lực phấn đấu. Thì đối với khu vực miền núi là chúng tôi sẽ cố gắng đáp ứng trong vòng 60 phút từ khi nhận cuộc gọi. Và khu vực mà trung du thấp hơn chúng tôi sẽ cố gắng là 100. Khu vực miền núi là 180 phút và khu vực trung du sẽ là 120 phút. Và khu vực đồng bằng thì chúng tôi cũng sẽ cố gắng là trong vòng dưới 60 phút với mục tiêu là dưới 30 phút là chúng tôi tiếp nhận cuộc gọi và xử lý bệnh nhân để đưa tới bệnh viện.
So 60 minutes is the time that from the Health Emergency Center we take to be close to the patient in the mountains area, which have less people and which is difficult to be able to reach out. And that was 420 minutes. And 60 minutes is for the people who lives in the mountain area as well, in a easier narrow to be able to reach you. And around 30 minutes is for just like a bit outside of the main cities or main town.
Và đây là một cái quy trình khi chúng ta gọi một cái ca cấp cứu. Thì người dân bắt đầu sử dụng cái số 15 qua cái số điện thoại hoặc là một cái app ở trên điện thoại hoặc là quét cái mã QR code. Thì những cái nội dung này nó sẽ truyền tin đến tổng đài cấp cứu 15. Em dịch.
For the people, they have three ways to reach out to the emergency center. Either call 115, or we've got our own app, or we have the QR code to scan.
Và tổng đài điều phối 15 sẽ tiếp nhận đánh giá phân loại ưu tiên trong vòng 60 giây.
And the operator will have a look at the situation and also the location within 60 seconds.
Và việc đầu tiên chúng tôi sẽ điều cái trạm mà trực thuộc là do chúng tôi quản lý để tiếp cận.
So the first thing is they will coordinate with their own emergency station first.
Và sau đó nếu cái trạm này mà không có thì chúng tôi sẽ điều cái trạm của các bệnh viện, của các trung tâm y tế.
And if the area doesn't have
cuộc gọi tới khi mà chúng tôi tiếp cận và thì dưới 5 phút để mà xe cứu thương di chuyển tới hiện trường.
They aim to be ready since receive the call until the time that the ambulance can leave is within 5 minutes.
Và chúng tôi đang nỗ lực cố gắng để có thể sử dụng truyền cái dữ liệu của người bệnh về tới bệnh viện mà nơi chúng tôi muốn chuyển tới. Và telemedicine.
And since the ambulance pick up the patient, they will use the telemedicine to work together.
Và tại bệnh viện sẽ có những cái đội mà phản ứng nhanh sẽ chuẩn bị sẵn sàng tiếp nhận bệnh nhân khi chúng tôi chuyển tới.
And the emergency people will be standby and ready before the patient arrives.
Và khi đó thì chúng tôi sẽ bàn giao với bệnh viện với đầy đủ tất cả những cái hồ sơ ghi nhận của người bệnh ở trên xe cứu thương.
And they will receive the patient and do the rest.
Và đây là một cái tháp phân loại cái khả năng đáp ứng của trong những cái trường hợp mà cái tai nạn hàng loạt có rất là nhiều bệnh nhân. Thì cái mức độ phân loại chúng tôi sẽ có cái khả năng đáp ứng để mà chỉ huy điều hành. Thì ở trên cùng các bạn cái tháp nhỏ nhỏ phía trên đó là cấp độ 1 là chúng tôi sẽ huy động là dưới 10 nạn nhân, chúng tôi sẽ có thể huy động từ 2 đến 3 xe cứu thương để có thể hỗ trợ cho người bệnh. Và đối với cấp độ 2 thì chúng tôi có thể huy động từ 3 đến 5 xe cứu thương. Và cấp độ 3 chúng tôi sẽ huy động từ 7 đến 10 xe. Và nếu trường hợp mà 50-100 thì chúng tôi huy động toàn bộ cái hệ thống cấp cứu ngoại viện theo cái sơ đồ mạng lưới để mà có thể đáp ứng trong tất cả những các tình huống. Và cuối cùng là kích hoạt hết cái hệ thống của thành phố để chúng ta đáp ứng các trường hợp đặc biệt là thiên tai, thảm họa và những cái vấn đề sự cố hàng loạt.
These are CAP is the level of the injured or the dangerous.
Many patients.
Yeah, of the patient. So if there's less than 10 patients, there will be around 2 or 3 ambulances and 1 nurse or 1 doctor. And then it just continue. And then if it's the disaster or the continuous traffic or something, then there will be the whole emergency station.
Và đây là một cái quy trình phân loại cái mức độ tổn thương của người bệnh. Sẽ có những cái màu đỏ nó sẽ theo cái mức độ, và tôi nghĩ là chắc các bạn cũng sẽ biết cái quy trình STAR để mà phân loại. Thì đối với màu đỏ là bệnh nhân có những cái vấn đề mà đe dọa chức năng sống thì chúng sẽ ưu tiên để mà xử lý kịp thời. Và đối với màu vàng thì những cái chấn thương không đe dọa tính mạng ngay tức thời thì chúng tôi sẽ ưu tiên để xử lý sau. Và màu xanh là những tổn thương và màu đen thì chúng tôi sẽ có những cái bước xử lý. Và tổng đài của chúng tôi nó sẽ phân loại theo cái tình trạng khẩn cấp để có thể huy động, điều động những cái xe cứu thương trong các tình huống khẩn cấp.
Red color is the most important one. And they will transfer the patient to the highest hospital in the list. The yellow is injured but not dangerous to the patient's life. So they will transfer them to the emergency station or the smaller hospital. And with the minor injury, then they will transfer it to the community health station in the ward or the city. And the black one is...
Và chúng tôi có triển khai một cái quy trình báo động đỏ ngoại viện đối với những trường hợp đột quỵ não. Thì nhận diện tại hiện trường đối với những trường hợp đột quỵ thì chúng tôi cũng đã truyền thông cho người dân và hướng dẫn người ta biết cách nhận diện sớm. Và chúng tôi kích hoạt cái hệ thống tổng đài 15 để mà điều phối trên cái dữ liệu. Và chúng tôi báo với bệnh viện để có cái kíp đột quỵ sẵn sàng để đón bệnh nhân và đưa lên vòng chụp CT hoặc là can thiệp sau đó.
For the stroke or or heart attack, the people are already trained on how to monitor the situation. And then later there will be the ambulance to so if we are there, we will know how to call the ambulance, to call the emergency center, and then they will take care of the rest.
Và trong năm 2025 là chúng tôi đã cấp cứu được 439 ca bị đột quỵ não và chúng tôi chuyển đến bệnh viện, kích hoạt cái quy trình thành công và chúng tôi chuyển và chúng tôi đã theo dõi đánh giá thì tất cả những trường hợp này đều được trong cái thời gian mà vàng để mà xử lý đột quỵ.
In 2025, they successfully received all the stroke cases and helped the patient.
Và Bộ Y tế cũng đang có cái thí điểm để mà phát triển cái hệ thống cái ngoại viện này để mà nhân rộng áp dụng cái mô hình của Đà Nẵng để nhân rộng toàn quốc. Và cũng xin giới thiệu cho các bạn biết đó là cái xe cứu thương của chúng tôi hiện có. Cái này rất là đẹp và rất là mới. Và trong xe chúng tôi đã được trang bị rất là đầy đủ tất cả những cái thiết bị. Và chúng tôi đã huấn luyện cho nhân viên chúng tôi sử dụng tất cả những cái trang thiết bị một cách thành thạo và làm tất cả các quy trình kỹ thuật để mà có thể thực hiện trên bệnh nhân.
So these are our ambulance with all the new equipment, and the nurse, doctors, and everyone are already trained to fluently use them.
Rất là sạch và rất là mới. Và các bạn khi mà người bệnh lên xe thì người ta cảm thấy rất là dễ chịu.
To comfort the patient when they are in the ambulance.
Và cũng xin giới thiệu cho các bạn đây là trang phục của chúng tôi. Tại hiện tại bây giờ chưa có một cái quy định nào cho trang phục của cấp cứu ngoại viện tại Việt Nam. Theo tôi biết được là tất cả các nước đều có. Tuy nhiên Việt Nam thì chúng tôi cũng đang thử nghiệm cái bộ trang phục này. Thì với mục đích là nó sẽ tự tiện dụng để cho chúng ta thực hiện ở ngoài, phù hợp với ngoài hiện trường.
And that's the uniform for emergency. Yep.
Đây là nội thất.
In Vietnam, they don't have an official announcement about the uniform yet, but this is what they are using these days.
Và cũng xin giới thiệu một nhân vật. Đây là một lãnh đạo của thành phố, là nữ. Và cũng xin giới thiệu cho các bạn biết đây là lãnh đạo của ngành y tế thành phố Đà Nẵng. Và đây là tôi.
Yeah, that's her and her colleague.
Và đây là lãnh đạo của Bộ Y tế, là người cao nhất trong ngành của Việt Nam. Thứ trưởng. Theo bộ thôi mình người cao nhất của Việt Nam.
Yeah, from the government.
Government.
Yeah.
Government.
Yeah, the highest. Yeah, minister.
He's got a question for you at the back here.
Yes.
Yes.
The actual staff of your ambulances, it sounds like you're sending out nurses and doctors in the ambulance, or do you actually have candidates?
Can you say again, please?
The staff of the ambulance, is it doctors and nurses?
Chị nghĩ là mấy người mà đi trên xe này để đi đón bệnh nhân đó chị, thì có chuyên môn là bác sĩ với lại y tá luôn.
Chúng ta sẽ bạn giới thiệu sau.
Yeah, she would introduce later.
Cái này hả? Nó không được nữa. Để trả lời câu hỏi của bạn thì cũng xin giới thiệu luôn. Đi trên xe của cấp cứu sẽ có một bác sĩ và một điều dưỡng và một lái xe cứu thương. The doctor and nurse and driver.
Yeah, on the
Two.
ambulance.
Đây là một cái kíp cấp cứu theo quy định của chính phủ. Đó là một bác sĩ và một điều dưỡng hoặc là một kỹ thuật viên và một lái xe cứu thương.
According to the government, there always have to be either one doctor or one nurse on the ambulance with the patient.
Và trên xe là bác sĩ sẽ có trách nhiệm là ra ý lệnh về chuyên môn, indication.
And the doctor will be the one who give the indication.
Điều dưỡng sẽ là người thực hiện các quy trình.
And the nurse will be the one who do the
Và lái xe sẽ có trách nhiệm là lái xe này sẽ được đào tạo để hỗ trợ cho bác sĩ và điều dưỡng. Em nghe được.
yeah, and the driver will be driving the ambulance and support if needed.
Thì đối với miền núi, hiện tại đây là một cái vùng rất là khó khăn. Thì chúng tôi có rất là nhiều cái giải pháp. Được rồi, cái slide này. Thì mà bản thân của đội EMS thì chúng tôi có phối hợp với rất nhiều lực lượng. Thì trong đó có là công an, police, phòng cháy chữa cháy, fire, and 115 là chúng tôi sẽ sắp đến sẽ là hợp nhất lại thành một cái tổng đài duy nhất, only one.
And these are the only one number that you call for police, fire, and ambulance. Yeah.
Và chúng tôi y tế thì sẽ có trách nhiệm là chuẩn hóa lại tất cả các quy trình chuyên môn kỹ thuật để mà chúng ta đào tạo quy trình.
Yeah.
I will later. Và đối với chúng tôi là cái paramedic hiện tại đang chuẩn bị để đào tạo. Paramedic, em dùng từ paramedic là
The paramedic are going to be trained soon.
Và chúng tôi cũng đang cố gắng là tất cả những trường hợp này sẽ được bảo hiểm y tế để sẽ được thanh toán chi trả.
And they are trying to get all of those cases to be covered by the health medical.
Và để trả lời câu hỏi của bạn thì tại thành phố Đà Nẵng là thành phố duy nhất tại Việt Nam tất cả các trường hợp cấp cứu của người dân sẽ được miễn phí.
Only in Da Nang City, all the emergency cases are free, but only in Da Nang City.
Lý do vì sao? Vì hiện tại bây giờ chưa có cái hướng dẫn của bảo hiểm y tế để thanh toán chi trả.
Because there's none official announcement about those cases yet, so it's free for now.
Và cái nguồn kinh phí hoạt động là do ngân sách của thành phố, government. Cái nguồn kinh phí là do chính phủ.
All the cases that are covered are by the fund of the Da Nang government.
Có rất là nhiều nội dung tôi cũng muốn là chia sẻ với các bạn, cũng muốn giới thiệu về Đà Nẵng cũng như Việt Nam. Tuy nhiên là Miss Quentin chỉ cho tôi có 15 phút. Nhưng mà hiện tại bây giờ tôi nghĩ chắc là quá giờ, rất là sorry.
There are more that she wants to explain and tell you all, but because he only gave her 15 minutes, so
và tôi cũng hy vọng là sẽ có một cơ hội khác. Tôi sẽ được Miss Queen cho tôi nhiều thời gian hơn nữa. Và qua cái buổi báo cáo này thì tôi cũng rất là muốn giới thiệu về Đà Nẵng với các bạn. Và tôi nghĩ rằng các bạn đã có một cái sự lựa chọn rất là đúng đắn khi đến tại Hội An và đến thành phố Đà Nẵng xinh đẹp.
She hoped there will be another chance to work with Miss Quinn, and he will give her more time to explain more. And she's thankful for you all for coming here today and for staying and visiting Da Nang and Hội An.
Và tôi cũng hy vọng là các bạn sẽ có những cái trải nghiệm rất là thú vị tại Hội An cũng như Đà Nẵng. Và bất cứ lúc nào các bạn có vấn đề gì về sức khỏe cũng như là cần một cái sự chăm sóc y tế thì cứ hãy gọi số 11.
And she hope you all have the best time here in Hội An. And if there's any health issue, please remember to call 115 while you're in Hội An.
Và tất cả các cuộc gọi của các bạn đều được miễn phí. Kể cả cái vấn đề chi phí trả cho cái cuộc gọi.
And the calls are free, so you don't have to pay for any fees.
Và cũng mong muốn là Đà Nẵng sẽ là một cái thành phố rất là đáng sống và là một thành phố là điểm đến của tất cả các du khách quốc tế đến tại Việt Nam và đặc biệt là tại Đà Nẵng. Và sẽ là một sự chọn lựa lần thứ 2 của các bạn để đến tại Đà Nẵng.
She hope Da Nang will always be your option whenever you think about Vietnam.
Xin cảm ơn mọi người cũng đã chú ý lắng nghe những cái nội dung tôi vừa trình bày. Và xin chúc mọi người luôn luôn mạnh khỏe và hạnh phúc.
Thank you for being here and joining us today, and wishing you all health and successful life.
Tôi xin kết thúc nội dung ở đây.
Thank you so much, Dr. Thao. It means a lot for you, for all of us, that you're here talking to us, and we really hope to continue the partnership and look forward to giving you more time next year. And also, I've got a new favourite person in the whole wide world, Scarlett, who came in last minute. Have we got a question? A comment?
Can you get Scarlett to come out and explain what happened to this beautiful room in October?
Oh, Scarlett, would you like to talk to us about that?
Well, if you gave me time.
So where you all here now was full of water and mud during October. So since 1964, last year was the highest flood that we had, and killed a lot of people, and especially for our hotel here. It took us 3 months and over to finally recover the whole basement, and especially this ballroom. Our hotel was full of mud and flood, the pool, the lobby area, the restaurant, everywhere. Yeah. Yeah. And it was one of our worst nightmares. Yeah. Yeah. But I'm glad that we are all here today, and you are not swimming under the water.
Thank you so much. Thank you, Scarlett. I just want her up here for every presentation, and I reckon after Rob's had a few beers, we might need her as well. So we're going to do Rob's presentation. I hate to mention time, but we're running over time. So if you do have tours booked or anything that you need to get to, no dramas at all. We are streaming, we are recording, so it's no problems at all if you do need to get up and leave at any stage. Otherwise, Rob, we good? Let's do it. Let's hear it for Rob.
Hello. Where's that doctor that just spoke? Where is? Just gone. Oh well. To Scarlett then. Gamoon. Gamoon. That was fantastic. How good was that? I can't follow that unless I come and talk about drugs. So let's just talk about drugs. Who recognises the plant? There it is, yeah. And so this entire region, Myanmar, Vietnam, Afghanistan, this whole region is, of course, a big place on the map when it comes to analgesia, from the opium poppy all the way through to our most modern synthetics that we use today. So, good afternoon, morning. My name is Rob Timmings. I'm from ECT for Health. I'm not going to give you a big bio, except I'm a registered nurse, a nurse educator. I work for the organisation called ECT for Health. You'll see that logo on every slide. It's marketing. And I'm so incredibly privileged again to have been invited back here by the boys to talk about pain relief today. Specifically chose this one because I knew that Dylan, who has gone, had to sit 7 hours yesterday under a tattoo needle, and 7 hours today. That's where he is right now, getting tattooed. So 14 hours of tattooing. I certainly hope he's got a little bit of embellishment on board. I want to talk about pain relief, and specifically where inflammation links to pain relief. This is a very different conference presentation to probably what you're used to at these bigger conferences. This is going to feel a little bit more like a seminar that's teaching about a particular topic. So if you have an interest in inflammation and pain relief and the analgesics that are involved, then stay. If not, it's an early mark for you and you can just watch the video later. Alrighty. Behind every pain score is a person trying to make sense of it. And I think that it would be true to say that we're trying to make sense of it as well. one of the biggest concerns that we have across the board, from pre-hospital medicine all the way through to post-operative care, is being able to control a person's pain. My theatre of practice is emergency, and about 78, probably 0.7%. Yeah, I went there. About 78% of people who present to an emergency department present with pain as central to their presentation. 50% get pain relief. We don't assess pain well, we don't manage pain well, and our clients, our patients, our family would probably say that we could do better in that department. So it bears thinking. Let's talk about what pain is. It's a noxious stimulus, it's perceived. And this is the important point when we talk about pain relief. We have to understand pain relief right from the get-go. If we can understand the physiology of pain, we can understand perhaps how to mitigate that, modulate that, and improve on that. Pain starts when an injury happens, and almost certainly inflammation's part of that process. I injure my tissue, I develop inflammation. Those inflammatory chemicals, that very, very early chemistry of inflammation is going to initiate a process of stimulating receptors, nociceptors we call them, and they essentially will fall into two pathways. We have a little bit like that thinking model that we've been talking about this week, the fast thinking and the slow thinking. We have slow pain and we have fast pain. That fast pain is the sharp, the burning, the stinging, immediate pain. That slow pain is your ache, your nurses in the room, your back right about now. Doctors in the room. The way that we manage pain, therefore, could be from a where the pain occurs point of view, right at the site of injury, by finding some sort of an analgesic protocol that's going to target pain where pain occurs. I dropped a brick on my toe, so it switches off pain at my toe, versus my perception of the pain, which would be a more centrally acting. And in this short presentation, so I've been informed. He's not here, I can take as long as I like. In this short presentation, what I'd really like to do is take you on a little bit of a journey through a number of strategies. We are not going to do all of the pain relief in the world, and you will have questions, and that's okay. I'm here all week. Try the fish. Righto. So it starts in the nociceptors, the pain receptors, and these are sensitised by either chemicals or inflammatory chemicals. It could be pressure, it could be temperature. But essentially, this is going to send a message to our spinal cord, the spinal cord up to the thalamus out through to our homunculus, where we're going to interpret that pain. From there, we make sense of whatever that stimulus is. And if that stimulus for me is that dropping a brick on my toe gave me what I would think was a 3 out of 10 pain, it doesn't mean that you don't have a 7 out of 10 pain for exactly the same experience. And I think that's where trying to objectify something that's incredibly subjective becomes really flawed in our understanding and assessing the pain model. Pain, remember, is what the patient says it is. Probably the most famous quote on analgesic or pain relief on the planet. Who said it? Does anyone know? McCaffrey says this. Pain is what the patient says it is. I have never been to a lecture on pain relief where somebody hasn't quoted this. So this was McCaffrey's words, 1988. Pain is what the patient says it is. The scoring is confusing. Are you confused by it? Who learned that 0 to 10 is our pain score? Who's learned that? Don't be ashamed if that's what you've learned. That's what I learned. That's what I teach when we're talking about analgesia. But where's the 10? Where's your 10? Is 10 the worst pain that you can imagine? No. Can you see just from the mumbles in the room that suggests that perhaps we're not all on the same page with this? And that's a problem, particularly when we're trying to objectify something that's subjective. We need some degree of consistency. So I think we're all clear on where 0 sits. I don't have any pain. But where the 10 is has to be meaningful to the patient, does it not? So if I said that 10 out of 10 was like, being boiled in oil or being mauled by a bear or like having a baby, gentlemen, do you identify? How can you? How can you possibly understand what a 10 is? If 10 is the worst pain one can imagine, I propose that 10 has to be the worst pain that one has experienced. Because it's a number the patient doesn't have to get right, it's their number. Do you really care what pain score is for the patient? If they said that it's a 7 out of 10 or a 7.5 out of 10, where is an ant? If you had a patient who struggled numerically to put a number onto that pain, does it really make a difference to you what you're going to do about it? We've got to stop linking certain levels of analgesia to a number. We've just got to stop doing it. Because my 7 out of 10 might get me some fentanyl, but somebody else's 7 out of 10 might get them some paracetamol. And I struggle with the equity of that. Question? And that's really sad. It's only linked to a triage score in our theatre of practice, though. In post-operative medicine, it's not. In GP medicine, it's not. In pre-hospital medicine, it's not. So we really have to understand that the patient's number is always correct. I don't care what your pain score is, mate. I just don't. What I care about is that you've given me a number, and that says to me that you're in distress. Now I'll do something about it. Now, whether that something is that I'm going to a locked cupboard and finding somebody, God knows who's got the keys today. Nurses in the room know my lament. Or whether it means that I'm giving something that's a simple analgesia, whether it's some sort of a gas that comes from a blue and yellow bottle or a blue and white bottle. Inconsequential what my strategy is going to be, I'm going to do something about that patient's pain, and what is far more meaningful than the patient's pain score is what the second pain score is going to be. 10 or 15 minutes from now, after I've given you GTN for your chest pain, I'm perhaps then going to say, well, how's your pain now? And whether you gave me a 7 or a 10 out of 10 before, what I'm expecting is that it's going to be something a little less. That's what's important, isn't it? It's that we have sought to improve pain. Do I have to know somebody's etiology of their pain to manage it? Do I have to send somebody to a CT scan to know that they've got a head tumour? Do I have to do an X-ray on somebody's bent-looking leg to know that it was a fractured femur before deciding on some analgesic approach? So this completely dismantles the model that we have as healthcare professionals, where we assess the patient, then plan care, and then implement it. If the implementation of that care was to offer some analgesia, the suggestion of that old school model would be that we had to do an assessment first. Well, let's just assess that the patient's uncomfortable and do something about it. And diagnosis for why they're in pain can always come later, can it not? I know that I'm pushing buttons, and that's okay, because I've got to start pushing buttons or we'll never get through these slides. So let's talk about the mechanism and the chemistry. Remember, there's stimulation of nociceptors or chemoreceptors. Tissue damage is probably the biggest, and that's the one that I'm going to focus on today. We could spend 6 weeks talking about pain, its physiology and its chemistry, but I'm only going to do inflammation with you today. Are you familiar with inflammation? Good. Is it a good thing or is it a bad thing? Is it necessary? If you went to the wound care talk yesterday, you would have learned, I didn't go because I was having a massage, getting rid of some back pain. You would have learned that the physiology of healing starts with, of course, stop the bleeding and then launch an inflammatory process before you can start the healing. You can't heal without inflammation. So, of course, it's necessary. It's necessary. It can be noxious. And certainly some of the biochemistry that's involved in inflammation is absolutely the contributing factor to our pain, our analgesia. So, let's talk inflammation. How do you recognise inflammation? Red. hot, swollen, painful, loss of function, in some circumstances fever. And if you went to the same kinds of school that I went to, you would have learned these good old Latin or Greek terms: red, rubor, calor, tumor, and dolor, good old Greek word for pain. With respect to my bride, I did go out with a girl in high school called Dolores, and every part of that was painful. Loss of function, and of course, occasionally fever as a systemic sign. Okay, so where does the whole inflammatory pain thing come into play? We need to understand that when I hurt my cells, when I injure my tissue, there is a chemical cascade that happens before the red hot swollen that you and I see. Clinically, we see a cellular response, but in the patient, we're going to have a chemical response long before we see the cellular response. And that chemical response comes all the way down to our cell membranes. Who remembers learning this from first year of medicine, paramedicine, nursing, year 10 high school, right? Every single cell has a double layer around it. We call it a phospholipid bilayer, meaning a double cell of phosphos and lipids, whatever the heck that is. The lipids are the cholesterol that's in the middle of every single cell membrane in your body. Yes, cholesterol is necessary for repair. And this phospholipid membrane is, of course, damaged any time that there is some cellular injury. Now, it doesn't matter what causes the cellular injury. It could be a burn, it could be a compression, it could be pressure, it could be a cut, it could be a fall over, a graze, it might just be inflammation, ischemia. It doesn't matter what the cause of the injury is, but there's injury to tissue, and that's the important step. You've probably seen similar chemistry like this, and you've flipped over this when you've looked at it in your medical textbook. But let me just take you there. And I was reviewing these slides while Doctor just before me was speaking, and looking at all her slides in beautiful Vietnamese language. There's not a single word that's longer than six letters. We could learn something about Vietnamese, couldn't we, in terms of the language, because there's some big words up here. So this phospholipid membrane is broken, and it's going to engage with those cellular membranes that are damaged and broken are going to engage with a number of enzymes. And the very first of those is called phospholipase. It makes sense. ASE is an enzyme. Phospholipase is an enzyme that dissolves or breaks down phospholipids. That makes sense. But out of that comes this magic production of what is commonly called in the food industry omega-6 essential fatty acids. But we call it arachidonic acid because we like to complicate anything, don't we? Everything in medicine seems to have more than one name. So this omega-6 fatty acid, arachidonic acid, is produced, which gives rise to this concept that our inflammatory chemistry is a fatty acid-based process. It's an omega-6 based process. Arachidonic acid is going to be produced, and now it's going to be acted on by two other enzymes, lipoxygenase and cyclooxygenase, and that, ladies and gentlemen, has changed your life. You're welcome. So let's just turn this off for a second and just talk person to person, clinician to clinician. I want to divide the room in half. This side of the room, your white blood cells, your leukocytes, lymphocytes and T cells and B cells and plasma cells and neutrophils and basophils and eosinophils and macrophages and all of the other white blood cells. That's what you are. This side of the room, you're every other cell in the body. Your platelets and your hypothalamuses and brains and livers and kidneys, and you're everything, but you're not white blood cells. You guys over here, you're all white blood cells. And you talk to each other. You communicate with each other. You coordinate a response using a language called leukotrienes. That's your language. What language do you speak? You guys over here, you're talking to each other in a language called prostaglandins. This is how brains talk to white blood cells and how kidneys talk to livers, and you're communicating in a language of prostaglandins, all different dialects of prostaglandins, but you speak prostaglandin. You speak, and you speak, prostaglandin. To be able to coordinate a whole of body cellular response in an inflammatory situation, we need to have leukotrienes and we need to have prostaglandins. And this is the crux of what this is all about. This is what inflammation's all about. So, you guys are bilingual. If you need to talk to them, you can speak prostaglandin to them. You understand prostaglandin, so they can talk to you, but you have to speak back to them in prostaglandin. They're a bit more simple than you. You guys, you can talk to these guys, but you must speak prostaglandin. That's your language. They understand you, they will speak back to you in prostaglandin. They're kind of elite like that. Anyway, back to the physiology. So, what does lipoxygenase and COX, cyclooxygenase, do with arachidonic acid once it's been produced? I'm glad you asked. Lipoxygenase turns arachidonic acid into leukotrienes. What language do you guys deal with? And COX turns arachidonic acid, omega-6, into prostaglandins. What language do you speak? This is the chemistry of inflammation, and it's these guys, prostaglandins, particularly prostaglandin E2, that sensitizes pain receptors and gives pain in inflammation. Would it make sense if we could shut down this chemical chain reaction? We're going to switch off pain at the site where the injury has taken place. It would be nice. And therefore, if I was to give a family of medications to a person to shut down inflammation, would it be fair and reasonable that those medications might be called anti-inflammatories? Would that be fair and reasonable? Fair and reasonable. Very good. So what are our anti-inflammatories? Well, our anti-inflammatories can be considered to be steroidal or non-steroidal. Our steroidal anti-inflammatories, they block phospholipase. Their job is to shut down phospholipase. So if I shut down your phospholipase, the steroids are going to switch off your capacity to make arachidonic acid, and therefore you'll have a diminished capacity to make leukotrienes, and you'll have a diminished capacity to make prostaglandins. If prostaglandins are causing your pain, can you see where the steroids can come into play? But there's always a catch, isn't there? Cost versus benefit. And of course, with steroids, we know that we have a number of side effects that are associated with those. So the steroids, you know of them as any of the analogues of cortisol. So hydrocortisone, dexamethasone, fluticasone, the list goes on. Prednisolone, prednisone, the list goes on and on and on. Immunosuppression is one of the biggest concerns. We have a number of side effects that we have to be mitigating or looking at against the benefit of these medications, and of course, increased infection risk. If I switch off leukotrienes, what's my capacity to fight infection going to look like? So it makes sense that if I'm giving steroids to a patient as a pain relief option, then one of the costs that I'm going to be having to deal with is the increase in risk of inflammation. Increased risk of infection. Depression and psychosis and mania. Have you seen this when giving particularly high-dose steroids to people? A blast of 50 of prednisolone when somebody's prednisolone naive can send them a little bit in both directions when we're looking at a bipolar spectrum. And I have some personal experience with this, with an episode of mania secondary to a dose of prednisolone. 50 milligrams. I was awake for 3 days. It was one-off dose of 50 milligrams. I was supposed to take 50 for 3 days and then de-escalate, but I just took the 50 milligrams and I was awake for 3 days. Yeah, I got a lot done. I've never ironed in my life, and everything was ironed, even the smalls, weren't they done? Gastric ulceration, colitis, and long-term steroids. What's our big problem when somebody goes on long-term steroids? When we think about that slow pain, that inflammatory, rheumatoid arthritic-y kind of pain, we've got a real Cushing's response, haven't we? That long-term problem is our Cushing's response. You've seen Cushing's? Cushing's, it's the best Cushing's you've ever seen. Of course, there's nobody in the world that knows more about Cushing's. Too soon? I was going to put a selfie up, but... All right. Non-steroidal anti-inflammatories, well, they just inhibit the cyclooxygenase, the COX. COX-1, COX-2 inhibitor medication, this is where our non-steroidal anti-inflammatory drugs fit. So if COX is responsible for the production of prostaglandins, and prostaglandins are responsible for pain, or are a contributor to pain, would it make sense that if we shut off prostaglandins, then we can shut down pain at the source? So the next time you're looking at an ibuprofen ad on TV for a brand in a silver box with orange sort of swirls on the box, I didn't say Nurofen, and they say targets pain where pain occurs, they're telling the truth. This is exactly how non-steroidal anti-inflammatories are working. By acting peripherally and blocking COX, we switch off the prostaglandin production process or reduce the prostaglandin production process, which naturally is going to provide less stimulus to those nociceptors for pain. You know of these as Voltaren, Celebrex, meloxicam, indomethacin, ketoprofen, the list goes on and on and on. Even our favourite aspirin sits into this class. Of course, things like GI bleeding and stimulating asthma attacks and all of those are side effects that we need to be mindful of, but one of the benefits that our non-steroidals are going to give us is that they are not something that's shutting down leukotrienes, so it doesn't have any real effect on reducing a person's capacity to fight infection. It does, however, affect platelets, and this is why we sometimes use that or exploit that side effect of platelet aggregation inhibition of aspirin particularly. Therapeutically, we use the side effect as a therapeutic effect. Paracetamol. Who knows how paracetamol works? We've only just learned it. We've only just learned. We don't even entirely know. In fact, the highest amount of information that we have learned about how paracetamol works has come out of the research on how cannabis works. Wouldn't it be interesting if paracetamol, all these years that we've used it, actually lit up the CB1 and CB2 receptors in your body that cannabis lights up, giving very good credence to the notion that perhaps there is a role for cannabis in pain management. And certainly, of course, that's old knowledge. So it is proposed that there may be some COX-3 function, but we're not entirely sure on that. Certainly COX-1 and COX-2. It inhibits the prostaglandin E2 production, and this is what gives rise to pain relief centrally. So it's considered to be a central analgesic, not a peripheral analgesic. It doesn't work where I drop the brick on my toe, but it works at the way that I might interpret that. There is some suggestion that it may actually mitigate the descending the descending pathways through my spinal cord. I've lost the word in my head, but the serotonergic pathways down through my spinal cord, essentially telling my toe, thank you, I've got the message, you don't need to send any more messages. So that feedback mechanism. But most interestingly, paracetamol really has started to really excite the pain relief community by understanding that perhaps it's got a little bit more stimulation of those CB1 and CB2 receptors, the cannabidiol and the tetrahydrocannabinol receptors that we have in our body. So that mechanism is through metabolism of paracetamol within the brain and the spinal cord itself into AM404. There's a big word I'm not even going to try and pronounce. You can have a crack at that after a few beer Saigons tonight. These are the cannabis receptors. Isn't that interesting? I just find that interesting. This is what everyone wants to know when we get towards the end of a session. It's like, oh God, how long is it going to go for? There's 7 slides left. This is not included in the 7, so we'll call this slide 0. Remember me when we're voting on the best session for the week, right? Alrighty, let's talk opiates. How long have I got, Q? There's something really intriguing and beautiful about these poppies. I love the way that they're harvested. They're scraped, the seed pods are scraped, and they ooze a latex. Interestingly, people who are allergic to latex often have a very, very high allergic reaction to opiate medication. Latex is latex, right? It's any white sap that comes out of a plant. So you think of rubber as latex, you think of this as latex. It comes out, it looks like PVA glue when it comes out, so it's scraped. But then just like an apple that you would have bitten into back in the 1980s, and there's some in the room that look like you possibly could remember the 1980s. Do you remember you used to bite into an apple and half an hour later it turned brown? Yes. Apples don't do that anymore, have you noticed? They just don't turn brown, they just don't oxidise, they're genetically modified. When the government puts those chips inside them so that they can read your thoughts. So it oxidises. It oxidises in the same way that a lot of fruit will oxidise, so too the latex will oxidise. It turns into that browny kind of colour. It's scraped off, stuck in a bucket, and it goes God knows where they process it, and that becomes opium. That's your opium, that latex itself. Now, the big question is, what's the difference between an opiate and an opioid? Well, that's not a big question, it's a very small question. An opiate's natural, an opioid is something that behaves the same way as an opiate, but maybe synthetic or partially synthetic. So when we talk about what is a true opiate is something that comes straight from Papavertum somniferum, the flower of sleep. Isn't that beautiful? Take enough of it. Good night, nurse. Papaver somniferum. I'm going to show your age. Who remembers Papavertum, the drug? You knew of it as Omnipon, and you used to give it pre-operatively, didn't you? Omenscop. Remember the good old Omenscop. I don't know where it went. It disappeared somewhere. But Papavertum was probably the first derivative that came from morphine that we first used. So it went from opium to morphine and its derivative, which was diamorphine. Morphine that was then further synthesised, it came down to codeine, and the unfortunate thing with codeine is that there's about 8% to 10% of the population that just can't process it. If you're from Australia, you'll remember just a few years ago, 2016 actually, 27th of September, at about 4 o'clock in the morning, they took codeine off the market and you couldn't... It was a sad moment. You couldn't buy Panadeine anymore. I wore a black armband for a week. Oh no, that was the date that Tim Tams went from 13 to 11 biscuits. I knew that there's 2 significant dates in my life. 3, if you count my anniversary. Alrighty. Opioids are going to be the natural or semi-synthetic. So when we think of things like the old-fashioned pethidine, we think of the newer fentanyl, meperidine, which is pethidine, the newer synthetics. Methadone. And then we have combinations, the combination opioids and SNRI medications, drugs like tibentadol and tramadol that light up not just the opiate receptors but also NMDA. They light up serotonin and norepinephrine receptors. So let's talk about what are the receptors that this opioid or opiate is going to attach to. And really there's 3 big ones. They're the mu or the mu receptor, the kappa receptor and the delta receptor. And we focus mostly, in the world of analgesia, we focus mostly on the mu receptor. So when we're talking about mu receptor agonism, you can see that if you have a substance that's going to light up those mu receptors in the central nervous system, you will get analgesia. That's our goal. But of course there's always a downside to that, and that is you're going to light up other effects or side effects, and sometimes those side effects could be considered to be adverse effects. And of course respiratory depression, meiosis, pinpoint pupils, euphoria, certainly a side effect. One would argue as to whether it was an adverse effect. Reduced GI motility are going to all be important features there. To get really clever with this then, why don't we give you an analgesic that is opiate-based but will then switch off some of these respiratory depression effects. Why can't I give you an opioid that lights up all of these receptors, but we can switch this one at the top off? We can give you a mu antagonist at the same time as we give you an opioid, which is a mu agonist. And that's, of course, where these antagonist combos come into play. Who's heard of Targan? Who's uncomfortable with the fact that I said Targan? Where are you? Where's all my Targan haters? I hope this is being recorded. Camera, zoom in on this. It's Targan. It's never been Targan. It will never be Targan. It's Targan with a hard G. Everyone say Targan. This is the last time you go back to work and call it Targan. I can give you some papers. I just can't give you p-values. You know I want to. Okay, so what that naloxone is going to do is it's going to switch off the mu receptors, therefore respiratory depression is not so much of an issue, yeah? I'm still going to get constipated. Yeah, still get a little bit of constipation, but it's not as much. We still have kappa and delta receptors within the GI. You're absolutely right, it minimises that. It does help, but it's just still binds you up. You still need a good fur to loosen things up a little. Direct nerve agents, these are analgesics that often will act directly on the nervous system. We think of things like local anaesthetics, anything that ends in cane. So lignocaine, propilicaine, bupivacaine, oxybupivacaine, even cocaine, of course, was our first anaesthetic, our first local anaesthetic. Norepinephrine as a neurotransmitter, when it's stimulated, tends to have pain-reducing effects centrally. The whole reason that when you cut yourself in anger or injure yourself in crossness, that you don't feel the pain is a norepinephrine, serotonergic norepinephrine response. So part of your sympathetic pathway of flight and fight, save your life, escape the being chased by the polar bear, because that happens a lot in Vietnam, is that you need to activate your flight and fight response and not feel the pain from the fact that you've already been bitten. You've got to be able to swim from the shark after the first bite to save your life. So by switching off pain, anthropologically, we're able to survive the threat, essentially, through that norepinephrine pathway. It makes sense, therefore, that when I'm giving somebody a medication that may be stimulating serotonin and norepinephrine pathways, such as our SNRIs, our serotonin norepinephrine reuptake inhibitor antidepressant medication, there's going to be some effect, some nerve beneficial effect on nerve-related pain, neuropathies, things like post-herpetic neuralgia, and other nerve-related pain. Our antidepressant medications of old have reinvented themselves as analgesics. And our last slide, and I only just slotted this one in this morning for an ant, but he's gone. Isn't he a fan? He loves it. He loves it 7.34% more than everybody else. Who doesn't love some Special K? So it kind of sits out on its own, the Special K. Look, I must admit I love ketamine too, and it was interesting that he called for ketamine use in an ambulance. Who's seen ketamine when somebody's waking up from ketamine? It's not a comfortable experience for many patients, and I couldn't imagine anything worse personally, waking up halfway to hospital in an ambulance from a ketamine hit. After being in the K-hole, which is a nice place to be, coming out of the K-hole can be a bit of a treacherous climb out. And I think that that would be really quite frightening. Interestingly, somebody I was talking to yesterday said that there's quite a lot of tattooing going on in town here under propofol and ketamine. You can go and have your big tattoo done under ketamine. Can you imagine waking up in a tattoo parlour halfway through because the ketamine wore off? Having a total freak out? So what does ketamine do? Well, NMDA, it's an NMDA antagonist. What NMDA, right now, you're concentrating on what I'm saying. I'm hoping you're not bored. And what's keeping you here in the moment is your NMDA. Well, what if I blocked that? And then your mind will wander. You'll go elsewhere. You'll dissociate. And this is why it's referred to as a dissociative anaesthetic or a dissociating anaesthetic. A person literally is going on a little trip. So, look, who doesn't love it? We're done. It's lunchtime. But I'm happy to take some questions. That was a really, really quick...
Any questions for Rob before we wrap things up? Great.
Yes. Yep. Mm-hmm.
I just said out in the community and for chronic pain, neuropraxias, nerve pain, auto-inflammatory disease, which is we are seeing every single day in the emergency department, low-dose naltrexone and PEA. Now, PEA has been around for chronic pain and neuropraxias for a long, long time. PEA's got over... It's huge.
I'm really embarrassed. I've got no idea what PEA is. Does anyone else know what she's talking about? No? Can you tell me what PEA is, please? Because I feel dumb.
I can't give you the big name now, but I'll do it for you. I work in a functional medicine practice as a functional medicine nurse practitioner. So I deal with gut, thyroid, chronic disease, autoimmune disease, thyroiditis, fibromyalgia, MCAS. And low-dose naltrexone and PEA work really, really well with those chronic disease things. So
I'm going to look up PEA. I always thought it was like when your heart's got a rhythm but you have no pulse. Different theatre of practice. Thanks, everyone. Thank you. Enjoy your lunch.